Hello, am I the only one? My name is Lilian Mavridar, and I'm grateful to be able to live both on the East and the West Coast, and then coming from the Mediterranean countries. So there are a couple of points I would like to address. Kate, you're not on your own. So I'm a psychologist. I'm coming from the mind, body health, and lifestyle medicine, and preconception matters at all levels. So we talk in here for nutrition, but we have to consider the emotional and mental nutrition as well. The way that the mother-to-be is coming into the pregnancy is the way she will come out of the pregnancy. I believe that no matter how much diet and nutrition we can provide to the woman, if the moment she comes out of pregnancy, she's left on her own, everything will go back to hell. So that support has to be there from the beginning to the end. Pregnancy and postpartum is a women's health topic. We cannot separate it. One of the colleagues made a very good comment. We cannot separate it from any other stage in a woman's life. And how this stage will go will affect her life and health as she grows into her wisdom years. Pregnancy and baby is a community topic. We cannot separate from them. I think, who's the gentleman? He mentioned very well that if the support for the woman after pregnancy is not there within the first weeks, the woman cannot make it through. For me, it's common sense. And we see more and more women who are on their own through this process, whether it's because they are in a community where they are far away from their families, and instead of reaching out, and mind you, it's not a criticism, it's just an observation that I have seen in 23 years that I have been working with the women's population. We don't tend to reach out to get help and support. We tend to close in and expect everything to happen, and that's not how it works. I would like to see more of the stress and the study on everything. We don't emphasize the role of stress enough. We know that it changes hormones. Well, if hormones change and the assimilation of nutrients change, well, that's an issue, whether you're pregnant or non-pregnant, and that will affect the placenta. And then, of course, I know we cannot do that many studies on the placenta, but until we have those biomarkers to do that, we need to keep that in mind. We didn't have biomarkers to work with nutrition 20 years ago, and even now the studies that are coming out are from 2014, 16, 17, and now. And lastly, two things. So it's stress I would like to see more being mentioned, and also the environmental pollution, not only as smog, but also sound, also EMFs. There are some groups that are doing now research on the role of EMFs on babies' brains, and it's a very scary feeling. And then it's like, okay, is it nutrition or is the reduction of all those devices and the baby sleeping with a cell phone next to their brain? I think my wish is through my comments is we have to think of this holistically. Mm-hmm. Nutrition, yes, it's paramount important. And we have to work at the community level. There are groups. Blue Zones has magnificent community-based education, foods, support, making communities walkable, which means that people get to meet each other, and therefore you have more support. So we have to think more at that level of change and improvement for the health of the babies and then for the health of the community.
Thank you. Other comments? Please.
Yeah, Patsy. So what I wanted to just bring up for your consideration is WIC as a model for care through pregnancy that goes beyond the participant level, for the general population. And so what I'm thinking is that, women who come into the WIC program, beyond getting just a food package, they get nutritional assessment, they get nutrition education, and I think most importantly, they get an intact referral system that it helps break down some of those stovepipes in clinical care that so many women have to navigate through as they go through a pregnancy, and particularly a first pregnancy. So I know you had a WIC experience when you were working with us, and I'm just curious to know what your thoughts are about whether or not WIC can serve as a model for care during pregnancy that helps broaden the woman's experience and her access to beyond traditional care.
So I would like to see some research on that, but having seen the model in action and having heard Raphael's research and Angela's as well, it seems to me that it's a very good place to start and to look at that. It's anchored in the community. It is in the deficit model. I think one of the interesting issues that Raphael raised is, could we move WIC into an asset-based model? The other issue that I'd raise is one that we haven't heard anything about, and everybody fasten your seatbelts. We haven't talked about fathers at all. And fathers are really important these days. When I grew up, my father didn't feed kids and he didn't change diapers or anything else. That's not what many fathers are like now. And not all fathers or other caretaking parents are engaged in all the process, but I think we focus so much biologically on the mother-infant dyad, and that's very important, that we don't think about what's the father's role in this. And I think that would be an interesting thing to think about if we expanded WIC as well. And I want to drop a little tidbit in your hat, which is there is evidence, particularly from animal models, that fathers too contribute to DOHAD through epigenetic mechanisms that can be nutritionally based. So if we're going to think preconceptionally, I want us to start thinking broadly about the reproductive triad, if you will.
So we have a question from the webinar, but this is also a question I think that came up in the last panel. And so I'm going to throw that out, and anybody can really answer this to some degree. Is when we're looking at other countries for models for how they deliver maternity care, one of the models that this particular individual is mentioning, which is one that I'm familiar with, is in Cuba. So in Cuba, what you basically have is this public health approach where you have one doctor per 1,000 members in your community. And then that doctor really knows their community very well because they're living in that community. And then the next level happens to be a polyclinic where other things get referred to up to the polyclinic, and then you keep going up until you finally sort of try everything you possibly can, and then if there are if things don't improve, you end up in the hospital. So and one of the things that they also do specifically for pregnant and lactating women is they have maternity homes. And so young women, adolescents, as well as anybody with GDM or anyone considered high risk, goes to these maternity homes in their communities, and they are given nutritional care. They're given nutrition education. They're provided foods. The doctor comes and visits them while they're there to make sure that everything's going well. They end up staying for a while, and it's also required that their families come and visit. So here's a very interesting model. There's certain models as well in Africa that have sort of, done this, a maternity home to help reduce maternal mortality because of the fact that they might be living further away from a hospital when they need to deliver. So could we potentially use some of these models from other countries to perhaps improve our care in the United States? So it'd be nice to sort of open this up. We've got another mic if anybody wants to, in addition to Patsy, comment.
Yeah, I don't know those models. I would comment in a little bit different vein about Finland and how they deal with infants born with fetal alcohol syndrome, and they have fetal alcohol effects. They have far less severe long-term outcomes, but they have very intensive early intervention. And one of the reasons why they can do it is because in their model of prenatal care, there's very close interaction of a paraprofessional linked with their physician with the pregnant woman. And so, and the community knows. People actually call and report to the doctor's office if they've seen a pregnant woman drinking. It's a different community sense of responsibility. So I think being open to other models is going to be really important. Raphael, do you have something you want to comment on this?
Just what I have seen in England, and it's probably the case in all European countries, the field of midwifery is way, way much more developed than anything I have seen in the US. They are very respected, relatively well paid. They can actually, perform many of the tasks that here would perhaps you would only expect a physician to perform, and they do home visits during the first weeks after birth. So I would say that it would be worthwhile exploring in the U.S. If there is an opportunity to advance much more the midwifery programs, make them more mainstream, and actually recognize them in a very, very good way.
And that brings to sort of my recollection about the fact that in certain communities, there is this movement towards the 4th month doula, where in fact, it is the woman who has helped out during pregnancy also stays there throughout the postpartum period to help with lactation and taking care of the mom. And there are communities who have done sort of sister doula so that they match women's race, ethnicity, so that there is that kind of peer support that allows for more of the cultural sort of acceptance and sensitivity to providing that kind of support. It would be nice to sort of scale up something like that.
Sort of a question more than a comment, because one of the things that we see from some of the grassroots when you talk about doulas, or we found with some of the grassroots women of color that are focused on improving health during pregnancy and lactation. So something like this workshop combined, and I think it even speaks to the community-based work, both community-based participatory research as well as community-based practice, somehow these two communities don't come together. Mm-hmm. So whatever we can do to facilitate that, I'm not sure what's the best way and best approach, because even recently, as we were working on this breastfeeding equity project, we realized that even I didn't know all these women of color, which are African-American women, exist that have been advocating for breastfeeding and have been working around breastfeeding and supporting women in breastfeeding for years. And then I go to a picnic, a Black breastfeeding picnic, and there's all these women there. And I'm thinking, they didn't know we exist, and we didn't know they existed. But they're really at the forefront, and I'm sort of a Johnny-come-lately person in this space. And I think something like this workshop, I would be very curious on how some of those grassroots people that are working at the front line and those grassroots providers and community advocates, how they would react to some of this, and how do we get that knowledge to them.
Hi, my name is Nikki Plaskett. I'm who you were asking for. Grassroots activist and breastfeeding advocate. I am an IBCLC, and I just wanted to give some accolades of models that exist in the system that are working. We have WIC locations that are coupled in hospitals in the district and at clinics where patients have access immediately to the program after they complete their visit. I know Unity has a WIC location at some of their health facilities. So does Children's Hospital. They have a WIC location that is on the same floor as one of their pediatric clinics in the Anacostia East of the River community. There is also a rapid housing program in the district called Elizabeth House, and I think it has an affiliation with Covenant House, where they provide rapid housing to teenage moms that are pregnant, that are dealing with issues of housing security and food insecurity. And they also provide continuing education. The moms are welcome to live at the house until their children are school age. The moms are always also encouraged to continue their own academic pursuits. And they are also put in line with a lot of the social services in the district, so they don't have to do a lot of the groundwork. And I fortunately have worked as a volunteer with that organization and as a professional in many regards, where the mothers receive exposure to holistic care. They have yoga classes, they have breastfeeding classes, and they have in-house lactation consultants during the day. So I just want to let you know that there are some community efforts on the ground that are successful, but there's a loss in translation from what happens in this room to what is implemented as policy. And it's very unfortunate. I know several clients that don't even report that they're breastfeeding moms because they're dealing with food insecurity. And if you report to WIC as a mom that is formula feeding, you have a different list of produce and a different list of groceries that you are able to receive. And you also receive emergency formula or cases of formula that you can share outside of your household to other members of your friends or your families that you know are not successful or not interested in breastfeeding. So I think that the program definitely can benefit from a greater community presence in terms of meeting the needs of the people in the community and translating their needs into policy. Because someone mentioned before, it's hard to find a mother that's not concerned in providing the best for her child and consuming the best foods nutritionally, but they just don't have the exposure, the education, oftentimes the time or the access to take advantage of the programs that exist in the city. Thanks.
Hi, everyone. My name is Justine Cavley, and I've primarily worked on program implementation and research in low and middle income countries, but it seems to me that we didn't really discuss, I think we touched upon it a little bit, I think Raphael mentioned it, was the quality of nutrition counseling that's provided. And I know, I don't know as much domestically, but in low and middle income countries at antenatal care and postnatal care, very little counseling is done, and we don't really know about the quality, and we don't know much about the content of what's provided. And secondly, even on weight gain during pregnancy, women don't know how much to gain. Providers don't know what the recommendations are. And so women are just left to figure out themselves what they should be gaining. And so one of the things I was just reflecting on was that you mentioned models, and I was thinking about the model in Kenya on Baby-Friendly Community Initiative. So it's an offshoot of Baby-Friendly Hospital Initiative. And there the government decided they wanted to continue improving breastfeeding, but they also wanted to incorporate elements of maternal nutrition and complementary feeding. So they actually formed community support groups that included other family members like fathers, community leaders, grandmothers, and they would decide what issues on nutrition they were struggling with, and they would talk about them every 2 months. And then in addition to that, they would have mother support groups where mothers would come and discuss about their issues specifically on breastfeeding and anything related, like complementary feeding or maternal nutrition. Every month they would have a different topic. So it's kind of also maybe thinking outside of the box, but if we wanted community-driven, couldn't there be some of these community initiatives that pair with what's happening in the clinical setting, so that you would have a continuum from clinical services to community services and have that network of support to be able to provide that and to be able to support, and maybe also to be able to dispel all the information we're getting from the internet and what's being provided on what is good nutrition. And I guess the fourth thing I think is that physicians don't really know much about nutrition, and there should be set curriculums and for them to really get the evidence pre-service while they're in medical school so that they're able to actively be able to counsel women during those consultations. And also they have issues on their time, and if they have quotas on patients, then how are they able to have enough time to provide quality counseling? So those are just some thoughts. Thank you.
Thank you.
I have a quick thought, and but I don't know anything about this. Raphael had mentioned, looking at different models, and I think there's so many models out there right now that we should take advantage of evaluating and making sure that nutrition is part of it. And I'm thinking about group prenatal. I don't know if anyone mentioned it over the past 2 days, but it's quickly being adopted, and there is some little bit of nutrition in there, but not really nutrition. So there's a lot of activities, but this is a model that the women love. So the literature is very clear that the evaluation of group prenatal and Expect With Me and some other offshoots, the women are highly satisfied. They're learning a lot. They're engaged. It's not. The literature is a little mixed with regard to the outcome, but nutrition really needs to be in that. And then the second one is food as medicine. Food as medicine is really taking off across the country, where healthcare providers provide a voucher or a bag of food, et cetera, and provide food for their patients. And they can get very specific around certain diseases or just in general if it's a low-income family. But these are opportunities that we can really piggyback on and figure out how to scale up and how to make them work better in specific populations. And I think they would be really great in the pregnancy population.
So this is a very good segue for a local experience in Hartford. So my Health Disparities Center that I used to run when I was at UConn conducted 2 years of CBPR work with the Hispanic Health Council in Hartford. And it was an in-depth analysis with the key stakeholders, the community, families, and so on, as to what can we do. We have a little bit of money to invest in improving the food system. And to make a very long story short, the winning option was to have a produce mobile market that would go and stop outside WIC clinics, outside hospitals, outside, places where there would be essentially, lots of women with young children and their families. At the time when we were doing this, none of us was a farmer, or we had no idea how to operate a mobile unit, but the community came on board. The community started operating the unit, and the hospitals started releasing funds that they had through the Obamacare, the healthcare reform, for it's called food as medicine. No, they would give the prescriptions for the moms to give outside. So it's a microcosm in a very small city, which is the capital of the state, but a very small city. This is the way it happened, and the unit is still operating now, and it operates year round. So it is possible if we had a way to connect, through social network science and citizen science and so on, all these local groups that are doing these things, to know what they are doing, to learn from each other, and to empower them to become entrepreneurs and actually form a single front. That I would love to see something like that happening.
Thank you.
So one last comment, though. When we planned this session, and in particular this one, Angela and I discovered the fact that there were some randomized trials that looked at not only pregnancy-centered care, but also qualified health centers who had sort of improved care by including the pregnancy-centered model, but not officially the pregnancy-centered model that included nutrition. And they have a full report. We tried to get somebody to actually come and give us the results because it's a really interesting model, but the report was published like in 2016 and nothing's been done. So it's interesting that there are some demonstration projects that have occurred, and unfortunately, we haven't been able to take these projects and turn them into reality and scale them up. And perhaps that's where we need to go. But
Thank you for your engagement.